Hello, this is Elliott from the Ask El podcast. I'm the founder of the Revitalize Clinic, where we've helped over 6,700 people become pain-free, mentally well, and physically fit. Now, today we're going to take a technical slant on a podcast, which I'm really excited to do so with Dan Miller, who is a qualified osteopath, a clinical tutor, and a trainee in health psychology. How are you doing today, Dan?
I'm good, thanks, Elliot. Thanks for inviting me, mate. It's really good to be here. Interesting to see where the conversation goes. It's great doing these things.
I'm
It's
sure
exciting.
I'm sure it will flow.
Yeah,
So
no, I'm good.
I've got a few questions for you then, and I think the reason why it's so exciting for me to speak to you is that you've seen things from both sides of the coin, I suppose. Because for me, when I was studying osteopathy, I noticed that it had a very, very anatomical slant, arguably a quite reductionist slant. I don't think as much attention was placed on the psycho or the social as should have been. And you've gone to the other end of, I mean, you've taken your study so much further by now partaking in, are you in the doctorate phase of your?
Yeah. So obviously, I suppose I'll give you a little bit of context. So, like you were saying, Elliot, it was like in the early stages. I thought, if we can understand structure, if we can understand biology, if we can understand anatomy, then we can help people. We can apply manual therapy skills, and we can help people. And I loved that. I loved that interaction we had with people. I was a big fan of Andrew Taylor Still. I read a lot of his stuff and was amazed really by what he'd achieved by his knowledge of anatomy and physiology. But I was always a bit stumped in like manual therapy technique classes. I was a bit like, I didn't feel confident in palpation. Couldn't really understand really what was happening, the mechanisms. It didn't quite make sense to me. But anyway, I went along with it because that's what we do when we're osteopathic students, and got a lot from clinic. I found it struggling, like challenging, as we all did. But they qualified in 2014 and then went into obviously private practice, and quite quickly really questioned my role as a kind of osteopath. I really went through this kind of phase, like, I don't know what I'm doing. I don't know how to apply it. I don't feel I'm being like as positive or getting the outcomes I could hope for. And but then one patient just completely threw me. Like completely threw me. He presented with his wife. His wife took the case history for him. Really felt sorry for this guy looking back on it. He wasn't the healthiest of people, but they both wanted to change. They both wanted some kind of motive. They had a motivation to change, but I don't think they had the resources to do it. And I definitely didn't have the resources. I felt totally kind of underprepared in that area. But anyway, felt I could hopefully suggest some ideas around diet, some books to read, some ideas about some basic kind of movement, as much as I could felt that I could give. And then I'd come back the week after and I was like, oh, how did you get on with some of that stuff? I was like, I don't want to do it. I was like, but how could you go from that drive, that real big motivation to want to change, the next week going, no, just ain't bothered. I couldn't work that out. But anyway, cut a long story short, Elliot, the guy went on holiday for 2 weeks and was like, you know what, Dan, it's the best I've felt for 2 weeks. It's the best I've felt for like a few years. I went swimming. I was active. I was like, fantastic. Let's get you swimming again. Let's get something, really try and play on, what you wanted to do. I was like, no, I don't want to do it. I was like, how does that work? What's going on here? It's like, and he was like, Dan, I want you to fix me. I want to be fixed. And I had that kind of conversation with him. I said, look, okay, that's great, but it's a two-way street. I'm gonna do some stuff. I'm gonna hope you're gonna do some stuff, and hopefully we'll kind of meet in the middle. And unfortunately, I didn't get to see him again. But it really questioned my role as an osteopath, Elliot. Like, I was like, hang on a minute, there's something seriously wrong. I'm seriously like kind of unprepared for this stuff. So then started looking at psychology, because for me it was like it all starts with thinking. That's fundamentally, it was all starts with thinking. I was like, I can help someone physically, hopefully, short term, which was proving in this case. But mentally, I just thought, I don't even know where to go with it. So then we looked at psychology, did a conversion degree in psychology, conversion masters in psychology. Then I did a health psychology masters. And fast forward till now, Elliot, I'm on the doctorate in health psychology, part-time at University of West of England.
Amazing. And when are you graduating?
Well, funny enough, we had a little meeting with a small group of us earlier, had a little meeting. We're like, we reckon it's going to be 2022.
Nice.
But it's like, it depends on when the kind of our research project gets, like, we have our Viva and see when it gets, if there's any amendments to make. But hopefully 2022, all going well.
And one question before we get on to the bulk questions of the podcast. It sounds like when you first partook in the study of psychology, that you were searching for something and you were searching for an answer. Did you find it?
No.
Interesting.
Honestly, I would
So
love
interested.
to say, right, I'd love to say, Elliot, right, you know what, today I'm going to tell you how to manage this, I'm going to tell you how to manage that. I think this works really well. If anything, all that's come from it is more questions.
Amazing.
More questions. It has not, don't get me wrong, it's guided me down a really handy path. Like, it's pointed me in the direction of some like theories that really kind of like chime into my deep beliefs that I've kind of recognized. But I'd love to say to you now, Elliot, you know what, right? If we're working with someone low back pain, they're slightly fear avoidant, let's do this, this, and this, and they're going to walk pain free. But unfortunately, it's not the case.
Do you know what I find so enlightening about that is the image that comes to my mind, or the question that comes to my mind is, would you rather be a fish in a small pond believing it's the ocean, or would you rather be that fish in the ocean knowing that your task is now to explore that ocean? And it sounds like you found the ocean. And you've had the humility to actually look for it in the first place, which I think a lot of people aren't. I think a lot of practitioners have so much, for the lack of a better term, possibly cognitive dissonance, stubbornness, lack of self-critique, that they would rather think that they've got all the tools in their selective amount, rather than actually venture out and be curious to find what else there is beyond.
And it does get uncomfortable. It's like when I went into osteopathy, I thought, this is it. I'm going to cure every single patient I see. They're going to walk out on a pink cloud. And I was like, oh no, that don't seem to work that well. And then it was like, well, maybe psychology is the answer. I understand beliefs, I understand thinking. And the rabbit holes you can go. Don't get me wrong, they're all good rabbit holes, and I love reading about it. But you know what it's like, Elliot, when you're working with someone, it's like working with people is so invariable. Like, and it's so dependent on, and what I came to understand was, that in between those four walls of a clinic room, I don't know what happens, but something happens. There's a positive effect, hopefully. I can't tell whether that's the way I've been, the way I am as a person, my manual therapy skills, hopefully some kind of empowerment. But then that's only me. I'm not taking into consideration the other person, of like how they are that day, their experiences, their beliefs, their kind of motivations. And somehow in the middle, that kind of mixes up and something happens. But, and it's like, I used to take a lot of responsibility. I was like, oh, they're not getting better because it's more my poor manual therapy skills. It's like, no, they could get better regardless of my manual therapy skills, regardless of whether I think they're good or bad. It's far bigger for me. It's just there's just so much at play there.
Absolutely. And I think that's one thing which, because I've read more books on psychology than anything else since graduating, because I think that the depths of the mind is just endless, and the interacting factors and how multifaceted it is. And even, now when we come to, we'll talk about this in a second, but when it comes to the biggest predisposing factors for pain, for me, the way that I interpret it is when the patient has lost control, and when the patient is in a state where there's no hope. And when all of these things are combined, whether it is depression, sleep deprivation, anxiety, poor diet, all these things which are starting to stress and take up that patient's ability to adapt, combined with the psychological factors of, poor coping mechanisms, no hope, financial distress, all these things, they all bump up the likelihood of that patient experiencing chronic pain.
No, I agree. And somehow when we're working with people, we've got to come to some kind of agreement, whether it's some kind of agreement subconsciously or, that kind of thing, right? Okay, there's a few steps here we need to take. It's not gonna be, I used to think it's 3 sessions, everything will be fine. But it's not, like you're saying, in that subgroup of patients that have those kind of contributing factors. It's so difficult, because not only that, we might notice that, but then do they have the desire to tackle it? And that's a really tough reflection, because it's like, because I think we can force ourselves, well, no, that's the wrong word. We can apply ourselves to people and say, look, this is going to help. This is what the evidence says, blah, 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 blah. But if they're not in the right place, or the right place to accept that help, or even accept the advice, then that's no one's fault. And I used to take that quite personally, but that's no one's fault. That's just the where they are at that moment in time. But I think the beautiful thing is that, Elliott, is that they know that there's a place they can go to if they're ready.
Absolutely.
And then we can help with, like you were saying, which is like amazing what you do with all the strength training and all the exercise work and all that. They're in that place. I want to try this bit. I want to try here. And it's like, yeah, we're ready. Let's give it a go and see how you feel.
Mm-hmm.
But it's that's what I found quite interesting. It's that, how can we develop that desire?
Oh, that's
in our patients.
Yeah, to be honest, that question seems so difficult to answer that I don't think I would have ever even asked that question, because that's a seriously difficult, because I suppose it, going into even deeper psychology is the question of, where does desire even come from? What are the thoughts or the emotions that are the foundations for desire? Because I don't think even that is a tremendously difficult question to ask. I think, does it start in childhood? Does it start in, is it nature?
I think you can tap into it. I think we can tap into it. Yeah, I think we can tap into that by asking certain questions. If we experience it, if we're going through that experience of managing someone who's in, going through persistent pain, or just, what it's like with those people that are like, what, I'm struggling at the moment, I don't know what to do. It's like, working with those people and saying, okay, what did you used to do that, you used to get a lot of fun from, or a lot of, like, what did you used to get up in the morning for? What was it? And that doesn't have to, I think I used to focus on purely exercise. I think it just has to be some kind of enjoyable activity.
Absolutely.
And I think if we can find that, again, it's like, I think the whole experience changes, because then they're like, what, I used to really enjoy doing this. Okay, well, then let's have a look at the barriers that are stopping you from doing that.
Just adding on to that, just, I suppose, giving testimony to that, I remember coming across a piece of research. In fact, Danny Orchard, also, me and Danny Orchard were talking about the same piece of research, which showed that you did not have to make a macro structure change in rehab to get the pain reduction. It's just the perception of improvement is enough to actually reduce the pain.
Yeah.
And in fact, that's what happens the majority of the time. That you don't say, I think the experiment was on grade 2 rotator cuff tears, that there was no macro structure change. It was just as torn as it was before, but the pain is less.
Yeah. What's all that about? And is that the fact that they've done something that they didn't think was possible, and you've just supported them through that change?
Well, I a lot of the time, the conversation that I have with my patients is I take them from a conversation which is based on the structural, the anatomical, which is what they think they're coming in with, and we talk about perception. And for example, this herniation or this muscle tear, which the ultrasound found, has been there probably for a long time, but your brain's only been aware of it, or aware of some type of injury for a certain amount of time. So we can just try and change the perception back to what it was, but we need evidence to give you that perceptive change. So the more evidence we can give you that you're actually doing good and that you're strong, the more likely you are to recover.
Yeah, I think that's fundamental, I think. But again, it's like, and that it's just, is the patient ready to hear that?
Oh, absolutely.
It's like, it's because it's like, what was it I was reading the other day? I can't remember. It was something along those lines. I think it was like a shoulder case history or something like that. That they'd done this case report, and the patient had, like, sort of had, I don't want to say failed at physiotherapy, but didn't get the results that they wanted. Say like 12 weeks worth of physiotherapy, rotator cuff tear, like shouldn't, limited flexion, limited adduction, fitted that rotator cuff, this like diagnosis. And then they were like, okay, surgery is probably the next best option. What had happened on, he'd actually gone home, he'd put his arm in his jacket, felt a click, felt a pop. completely pain-free, but there'd be no change on the scan. And they're like, what's this about? It shouldn't be, this should, full range, everything. Still the same kind of changes in the shoulder, but he's felt something.
Yeah.
And he's
amazing. Because often I have patients and they'll bend forward and they'll click their back and they're in pain, or they'll move their shoulder and they click their shoulder and they're in pain. And I'll often ask, what came first, the pain or the click? And so often it's the click that comes before the pain, rather than them being instantaneous. Almost like there is a belief which is attached to the click, which leads to the increase in pain or reduce, which I suppose is testimony to what we do as osteopaths anyway, when it comes to the manipulation and things like that.
Yeah.
One question I have, well, the first question is, how do you feel, going through your journey, how do you feel that osteopaths need to integrate their understanding or better understanding of the psychosocial into osteopathy?
Oh, that's a good question, Elliot. Like, how do we feel that we can implement it more? I think it's, if we look at the way the biopsychosocial model's coming through, as allied health professionals, this is one of the models that we should be using. But it's a real challenge, and I'll count like my experience. It's like, I'd like to see myself as slightly more psychosocial than some of my colleagues, just because of the way I've gone with my studies. But I still diagnose with a biological diagnosis and don't ignore the psychosocial. So maybe that's through training, but how can we implement it more? I think sometimes, and Peter O'Sullivan said this, I think if someone's presenting maybe with, what we may like illness, like some illness beliefs, or changing the society, changing like kind of relationships or something like that. I think sometimes we tend to, I'm take from my experience, not like generalizing. I used to think that I haven't got the experience in that area to manage that. I don't know what to do. I'm comfortable in the biology area. I'm comfortable with anatomy. I'm comfortable with physiology. If someone presents to me with some kind of illness beliefs, I don't know how to do it. And I'd shut off from it. And it's funny because then Peter O'Sullivan says, well, no, you don't have to do that. Because if a friend comes to you and says, you know what, Dan or Elliot, I'm struggling at the moment, mate. Lockdown's got me bad. I haven't seen my mates for ages. I've now started getting this like lower back pain that just doesn't seem to shift. And everything, my relationships, having a bit of trouble with my girlfriend, all that sort of stuff, work's let me down a bit. And it's like, if you were talking to him or her as a mate, you're not going to go, whoa. This is out my comfort zone now. You're going to ask them how they are. That's just human nature. You're going to say, well, sorry to hear that. How are you managing it? How are you getting on? Do you feel supported? You're going to listen to them. And the power in that, Elliot. And I think we can apply that with our patients without, and of course we have to be aware of our boundaries. We have to, OPS says that, we have, the osteopathic practice standards say we have to be aware of our boundaries. And if someone is presenting with, psychosocial complexities like mental health that we, like, for example, there's like been some history of self-harm, there's been a history of substance abuse, there's been suicidal thoughts, then we have to be ready to say, okay, right, this is now further. This a psychological referral is going to help you. I can help you with your pain presentation, but I think a psychological referral is probably going to be better for you here. It's just clinically recognizing, like we would do with red flags or something like that. If a patient presents to you with a complication and you feel actually this is probably going to need further investigation, you'd quite happily refer.
But you're
I think the psychosocial
explore those.
Sorry,
you're saying explore that space where to take it up to where the standards to take it up to your competence, and then explore that space. Okay.
Yeah, and I think as well, it's like, there's courses in motivational interviewing, there's courses in CBT and all that, which is fantastic, but it's quite structured. I think it's like a humanistic approach of just listening to the narrative. It is so powerful that we don't have to be psychologists, we don't have to be, CBT therapists. Just the fact that we're osteopaths and we're in a space to listen has its own powerful effect, because the patient feels validated, they feel listened to, and we can use that within our manual therapy. when we're doing manual therapy. You know, oh, you mentioned you're having trouble in your relationships. You know, do you want to explore it? And you can kind of judge it, can't you, Elliot? You know when someone wants to open up a little bit, and you know when when the right time is to maybe not like dive in with a question, but just say, how are you finding that? And it's just that I think it's that some questions like that are so powerful, and the qualitative literature backs that up.
Mm-hmm. That,
you know,
that open-ended discussion, or I've heard it called, is it cathartic conversation?
Yeah. Or Peter O'Sullivan and the cognitive functional guys call it like listening to they just basically tell me your story,
Mm-hmm.
and then leave it at that. And they're saying that, what they say is that, that's really going to get to the root, because then it's just purely guided by the patient narrative.
Mm-hmm. What's the power in it being guided by the patient narrative?
I think because we're letting the patient lead the experience.
And why is that?
So
go on.
I think because it puts them in effect. It puts them, they're the expert in their condition. They're the expert in their life. It gives them the time to tell you their story. So I think that becomes powerful, because if they've had an experience of other healthcare professionals that maybe haven't, they've maybe had short, I think what GPs do and other healthcare practitioners do are brilliant. But if they haven't got the time, which is through no fault of their own, of course they're going to say, where's your pain? How's it affecting your life? Are you getting severe neurological symptoms and that sort of stuff? Then, maybe it can feel that they're not getting an experience for what they deserve. But what the qualitative literature says is that like the healing, they call it the healing journey, because it's not like, oh, I feel great now. It's like the practitioners that have been working with let them have that supportive environment. They've been able to speak non-judgmentally. And I think there's so much power in that stuff.
It's so interesting with, I think, and it's probably just partly down to my own personal interest, but when it comes to reading about psychology, I've really enjoyed reading about the psychoanalytical stuff and learning about the hero's journey. And there's so much of what you've already mentioned which show correlations between the hero's journey and, say, the healing journey, i.e. the hero meets a call, or they have a mission and they have to go into the chaos of that mission to then triumph over it. And it's very important that the hero is the hero. You can't ask the surgeon or the doctor or the osteopath to be the hero. You have to be the hero. But the hero, amongst the many myths that we have as human beings, the hero can have a guide. It can have someone who shows them the way, but doesn't necessarily lead them the way.
It's that supportive. It's offering that supportive role, isn't it? Because we're not. There's an argument then, isn't there, Elliot? Then to say, well, as osteopaths or healthcare professionals, do we have to adopt some kind of coaching role? There's a question there, isn't there? Like, and then in that, that may change our approach.
I have to be honest, that's all I view myself as a coach or a guide. There is no way that I get my patients pain-free. All I do is show them the way to become pain-free. And when it comes to what I do with my hands, even if I was to take a very focused look at it, I'm really just unlocking or showing their body or their mind what was already there in the first place. What I do with my hands does nothing to their body apart from showing what was already there in the first place, that you can actually move this far, or it's not as, the tissue isn't as tough as you think, all these kind of things. So I completely agree with that. I have to be honest, that my work as an osteopath becomes so much more interesting when I viewed myself as a guide rather than as the practitioner who solves people's problems.
And I think that makes it more rewarding. Because it's so humbling. Because I remember, I'd never forget, it was a manners talk, right, at the UC or BSO as it was then, and I think her name was Susan Turner, was doing a session on balanced ligamentous tension. Do you know what she opened up with? She said, "No one is smarter than the human body." I was like, well, that to me, that was it. That was it. You know, it's like it took, well, it wasn't there and then. It took me time to understand it, but now I know what she means. I am no better than the person sitting in front of me. You know, it's Carl Jung, and well, maybe Freud a little bit different, but Carl Jung was like, spoke about the power differences within a treatment environment, and he's like, he puts himself on exactly the same plane, or if not below, the person he's working with. They are the expert in their condition, not me. And it's like, so if the patient says, "Oh, Dan, you know, I don't know what you did last time, but I come out of that session feeling a million times better," I was like, no. It's nice of you to say that, of course it is, but you fixed yourself. You know, I've just supported you, like you saying, you know, just helped you in that environment. I haven't fixed you. You've done that yourself. And I think that was quite humbling for me to realize that I don't fix anyone. I'd like to think I do. You know, the old ego me when I come out of uni was like, yeah, I'm gonna fix everyone. But you know, it doesn't happen like that, does it? Unfortunately, Elliot.
Absolutely.
It don't happen like that. But
got another question. How and why can how and why? My question is, how and why can psychology be a larger predisposition to pain than the bio and the anatomical?
Good question. Again, I suppose, you know, from what we understand about the biopsychosocial model, the critique of it is that how is everyone equal? Do you then silo people off into the bio, the psycho, or the social? But how does it impact on pain? I think when you look at, there was a really good paper by, I think the author was Nicholas Penny in 2010, spoke about how the concepts of osteopathy fit alongside the biopsychosocial model. And of course, so the biology is a tissue causing symptom, you know, all that neurology stuff, all the bio, the anatomy, and all that sort of stuff. But then you have, like, which is obviously related to structure, is related to function. And then you have the social and the social and the psychology side of it. And the psychology bit, it talks about illness beliefs, which, you know, goes back to what I thought, where it all starts with thinking. And then the social side of it, you've got obviously the sick role, and then alongside that, the osteopathic parts of it are the body has its own medicine chest, if you want to call it that. It's self-regulating, it's self-healing, it's you know, and all that stuff, and how they all combine. But when you just look at it as a framework, I think then you can kind of understand that, you know, and this is kind of touching a little bit on the psychology side of the common sense model, which is all about illness beliefs. If that person who's presenting to you or us has a history of long-term pain, has a history of trauma, has a history of mental health, you know, sort of depression and anxiety, and then of course they're presented with this pain problem, they come and see us, Elliot, of course there's going to be some psychosocial elements there that are affecting the biology. And if you look at the pain science stuff, which I'm, you know, kind of get a bit wobbly in, you know, that's, you know, I think it was what's his name, Laura Mosley talks about it, that impact, they might have an impact on inflammation, might have an impact on pain sensitivity or nociception sensitivity, if you want to call it that. But fundamentally for me, it's that if that person then believes, if you look at the common sense model, the pain event is the health threat, the illness domain or the illness threat is, hang on a minute, I'm not sure, a timeline, I don't know how long this is going to take. Control or cure, I don't think I can control this. This is out of my control. Consequences, this is robbing me of my life. And then the coping behavior with that is avoid, or, you know, I'm going to withdraw from quality of life or something like that. And then the individual appraises that. So then we're kind of stuck in this, like this cycle of, okay, and then you've got emotion in that as well. So you might have fear, you might have, you know, anger and all those other things, and their emotional mechanism might be, you know what, I don't want to do that activity because I think my back's going to go. So of course, this withdrawal from society or this withdrawal from quality of life is going to have an inherent effect on the biology, because, you know, all of a sudden our world gets smaller. You know, we're not moving our body as much as we feel that we could. But then on the other side of that, you know, the patient could have these illness beliefs. They could come and see you and you could go, you know what, let's just get you doing a few movements. Actually, you know what, you're actually moving really well. You can do a lot more than you think you can. You know, it's that kind of you feed in and maybe a little bit of graded exposure.
Sure,
You know,
just by you explaining that so well and so fluently, going into the psychology and then back into the biology and then the social, it made me understand the flaws in my own questioning, in a sense that I realize, and obviously, tell me what you think, but the human body and the human mind have evolved as one without any segregation between any different systems. So even the way in me asking what has more of an influence, the psychology or the biology, is not being actually true to the human form. And I was going to ask you, do you think that we impose our own belief systems on something which is far older and far more complex than our framework for understanding it?
yeah, I think, it's part of some of the critique of osteopathy, isn't it? Are we still stuck in this biomedical tissue causing symptom kind of paradigm? That then you look at the person, and then you look at the work that Ollie Thompson's been doing with Cause Health and with Peter Stilwell, and I can't remember the other, Stilwell and Harmon, I think, about the role of environment. So now it's like that they're not separate from their environment. You can look, you can't work in, the paper, the inactivism beyond the biopsychosocial model paper. The authors say that there was a study done where they had two people on the top of a hill, and one person was on healthy individuals. One was on a skateboard, the other was just standing on a box or standing on the hill. The person on the skateboard saw that hill was steeper. Now, if we apply that to someone in pain, we could be in exactly the same environment. I don't know, say for example, they've gone to try a gym or something like that. They're in an environment, but they don't feel safe. They don't feel comfortable. They don't feel, they don't feel that they should be there. The trainer is a really fit, healthy person, and they don't see themselves identifying as that. So before you know it, the environment for one person is an amazing place to be. For someone else, it's the opposite.
That's unreal.
And that's so if we take that as in the environment as someone who's in pain, rightly so, there's good, if we've all experienced some kind of pain event, all of a sudden you're like, oh shit, hang on, how many stairs can I get up? I don't think I'm going to be able to run for that bus. And that's as a healthy individual going through a short-term pain event.
Yeah.
What about someone who's had long-term pain with all that other psychosocial impact that we've discussed?
That's unbelievable. I mean, because to view that experiment being so simple, but that obviously, because we are interacting with the patient's perception. It's not an objective event that we're dealing with. We're dealing with a perception, a very subjective event. So then it automatically makes me put my mind in that patient, or for me to take the same lens that the patient's using and use it through my eyes, and realizing that, well, that thing which looks light actually now weighs a ton. That block of stairs is now going up 3 times as long as it is. That turning a normal wet slippery path into an ice rink. That's the kind of changes that can happen in our patients' minds dependent on the situation that they're in.
Yeah, I was like another area that I'm really interested in is pain behavior, like applied from the biopsychosocial perspective. So there was a paper that I was reading about, I think it was about around elderly people with, say, long-term back pain. And the thinking process that go on beyond that, Elliott, it's just like, I'm like, it's like, we all know, obviously, that the impact of social groups can have on the elderly, or writing groups or something like that. The power in that is just, it has everything. Social, your psychosocial impact, your relationship, you're related to others, you're doing something you enjoy, all of the above, right? This one of the sayings one of the quotes from the research paper was that I didn't want to go to my writing group now because I didn't know how long I was going to be sitting down for, or I can't bear to sit down. And so if we don't explore that, and another one was, I don't go to social events anymore because I don't know how many stairs are going to be there. And it's like, I think if we don't understand, I'm sure people do, it's probably my own reflection. I never used to even think twice about that stuff, Elliott. Like, I just, Why would I just want to know if someone can bend forward or not, but not the impact that that's having on the individual.
It brings up to me I don't know if it's a principle of osteopathy, what Andrew Taylor still said, which is go towards health. Anyone can find a disease, go towards health.
Yeah.
And then I suppose even for our patients, understanding as thoroughly as we can, what is health to them? What does health mean to you? Because, health to me is completely different to someone else. I might view health as being able to lift weights or do martial arts. For them, they might just want to go on a long walk with their grandkids or something like that. It's completely different. This definition of health.
And I think when we start understanding things like that, I think the whole treatment encounter becomes so rewarding, because again, it's like what you were saying, you were seeing yourself as that guide. If you can understand that, something that seems so simple to us is actually huge to the patient. Like the empathy, the rapport, the belief in you as an individual, all have positive effects on outcomes. Of course they're going to. You've touched someone's deep nature of like intrinsic motivation, desire. I just want to pick up my grandkids, and that's it. And if we can work towards that, I think. And as well, it's like we'll come on to, I think you mentioned we're going to talk about it later, but my research, I'm hoping to get, it's called, I'm hoping to do some stuff with living well with pain. Look at the behaviors that people adopt, for living well after seeking osteopathic care, to try and really sort of make the research a bit novel. But I was talking to, hopefully she's going to really help me with the research. And it was like, the kind of her pain experience, I just can't relate to. I which is why it's so good, like having her on board, because some of the questions that I might ask her, I'm coming as a researcher. If I'm like, how does pain affect your life? It's like, Dan, that is such a broad question. I can't even begin to go even think about what you're asking me. You need to break that down a bit, so it's like having that person's individual account. I think it's like that. It's that humbling experience where we fit ourselves to the patient. They don't fit themselves to us. Mm-hmm. We fit ourselves to the patient, and we apply our knowledge, our experience creatively to helping that person achieve however small that may be.
Could we go on to talk about your research now then?
Yeah, of course, mate. Of course. Yeah. So part of the doctorate is that I've got to do doctoral level research, and health psychology is, and as I spoke about some of the qualitative literature, I'm really, really interested in the patient experience. I think, what we've been talking about, Elliott, we can learn so much from an individual experience, far more than maybe we can about, I don't know, the effect of METs on improving hip range of motion, something like that, or HVTs improving whatever neurological, I don't know, mate. But if we can understand the illness experience, I think it really helps us develop our empathy, develop our compassion, and help apply ourselves creatively. I think if we can understand that. So what I'm really interested in is, I think, because obviously all we see is people in pain. That's all, that's all I ever see is people in pain. But what about those people that may be in pain, that adopt some kind of behavior that we don't see? And how have they developed that knowledge? So that's what I want to tap into, that part. It's like, so living well, I was kind of trying to tie it in with some kind of intrinsic motivation and use a theory called self-determination theory to ground it in that. But I've talking with my research supervisors, I want to kind of drop that, because I want to let the research go, literally take its own course. But the reason is, it's called public. It's not called, it's something like, it's probably something as simple as like public involvement. Like, we want to get our public involved in the research, because they're the people that I want to help. If I haven't got those people involved, it's kind of, there's still that disconnect. And it's kind of the big critique, like academia, like saying, you should be doing this, you should be doing that. The evidence says this, you should do that. So, and the people who it's meant to help are going, I have no relationship to that whatsoever. It doesn't even begin to touch the sides. Yet when we get people having that experience, being grounded in like the kind of question forming, data collection, theory, like theme generation as well, like I could come up with some themes and apply it to the person in pain and go, what do you think? She might say, It means nothing to me. It means nothing. You've completely missed a whole host of my environment. You don't know what it's like to have to think about going out.
Because
Something you take for granted.
what it sounds like you're doing then is flipping the, I suppose, not is I can imagine it being very normal for psychology, but if we go to more reductionist or allopathic roles when it comes to management of pain, most of them funnel down very specifically
Yeah,
into the patient, i.e. MET, HVT, analgesics, what's the effect? But you're doing the opposite. You're starting with the patient and you're funneling out and trying to get as much information about that patient
yeah.
as possible.
The,
And
the
what
patient has all the answers.
yes, that's what I'm picking up on, which is so interesting, is that if you can get what seems so small at first in terms of just a patient walking through the door and get them to open up and understand
Yeah,
their experiences and their story in as much detail as possible, then that gives you the framework of understanding, or at least the playing field to come up with a plan together. Is
yeah,
that right?
yeah. It's like
Amazing.
it's just putting the participant at the center of the research
Yes.
rather than the other way around.
Amazing.
I'm not saying that participants, that's I don't want to do research justice because it's really challenging, but it's like I want to understand what it means to live well to someone who's got long-term pain condition. What does that mean? And it's like what you were saying, Elliot. It's like it could mean something so simple that we don't have to like get a patient bench pressing cattle or squatting cattle. We just have to get them doing something they enjoy. If they're moving and they're enjoying it, it has an impact on quality of life. It has an impact on relationships. It had an impact on the belief in themselves.
Do you think that sometimes we're having to really catch up with how times have changed? Because obviously, early 1940s, say, just previous to when the NHS was formed, leading causes of death were things that occurred, high risk things that occurred in the day-to-day environment for many patients. For example, poisoning,
Yeah,
bacterial infections, workplace accidents. Whereas now, our idea of health is not steering away from harm's way, but it's living in the normal yet quite chaotic environment of the
yeah,
day-to-day situation and nativgating that as best as possible. So do you
yeah.
sometimes feel that we're catching up with that?
Sometimes I think it's just you think we've had this event of a pandemic and now we're coming out of it again. Hopefully, you know, it's affected people in so many different ways. You can hear that the individual stories people have either really suffered or actually they've been quite quiet, but they've actually really enjoyed the experience. It's like, so maybe health is going to change again. There's obviously a big focus on mental health, rightly so. But what does mental health mean? What does that mean? It's like, okay, does that mean I'm going to have no depressive thoughts? I'm going to be zero anxiety, and I'm going to be pain free for the rest of my life. It's like a utopia, isn't it? It's it's like you say, life has its own. Life's going to still happen. We're still going to unfortunately experience unpleasant events.
Mhm.
We're still going to experience anxiety. I'm still going to, going to feel fearful about going into work some days. I'm going to be, stressed about a deadline, or stressed that I'm not going to complete a module, or comparing myself to others. That's just normal day to day for me.
Mhm.
But at what point do I say, you know what, I feel great today? And is that then equate to health?
Mhm.
I don't,
Amazing.
I don't know. But for me, health is just that waking up in the morning, you go, and I feel all right today.
Mhm.
And
Having a fighting
I think that,
chance.
yeah, I think that's enough. If I can get up, go for work, and have a good old day, then have a laugh with my kids, have a laugh with my wife. But again, that might be minute by minute. That
Mhm.
might happen 1 minute, and the next minute I'm going, I just want to run.
Yeah.
I just want to run. But at what point, where do we class that as health?
Mhm. And I suppose they're questions that need to be answered. In fact, I've just finished reading Mark Carney's book called Values.
Oh yeah,
Yeah, and he's basically saying that there does need to be an objective underpinning for what health is or what
yeah,
happiness is. That's more from like an
yeah,
economical perspective. But yeah, no, it's in, and there's but then there are big questions big questions.
They're massive questions. It's like, obviously the World Health Organization tried to define health in the 1940s, and I think it was something along the lines of the complete, or is it not complete absence, or the complete psychological, physical, and mental health, or something like that. But the word complete was in it. I'm like, does that mean that it's one or the other? That it's either complete or incomplete? What about what about the spectrum of it?
Mm-hmm.
Physically, I might feel great. I might be able to go out for a run or do whatever I want to do physically, but mentally, I might be absolutely crapping myself about a job interview.
Mm-hmm.
It's this, and and the health psychologists have kind of tried to add in the word of perception
Mm-hmm.
and the satisfaction, to try and tone that language down a bit. But yeah, that's academic. Like you were saying, Elliot, my version of health could be very, very different to the person I see tomorrow morning.
Mm-hmm. Absolutely.
Yeah.
Dan, thank you so much for your time today. It's been so interesting for me to
Thanks, Elliot.
discuss with you.
Yeah.
Well, first of all, I wondered if you had a go-home message for any osteopaths or any healthcare practitioners listening to this.
I think it's be open-minded and be creative with the way you work with people. Don't be afraid to try things, and don't beat yourself up if it goes wrong.
And if there's anyone who is listening or watching and wants to keep in touch with your work or keep up to date with your work, is there any way that they can do that?
Yeah, you could. Yeah, I'm on Instagram, Danny Miller, or that's probably the easiest version, actually.
Yeah,
on Instagram.
No problem. Thank you so much, Dan. It's been an absolute pleasure speaking to you today.
Thanks, Dan. Elliot. No, it's Elliot, isn't it?
Yeah. Thank you.